Good evening. This is the House Health and Human Services Committee meeting. Today is Tuesday, March 30, 2021. We are in the House Lounge at the State House. We do have members online with us as well. Clerk, when you are ready, we can take the roll. Go ahead, Clerk.
Okay, here we go. Chairman Casey.
Here.
First Vice Chair McLaughlin. Second Vice Chair Donovan. Here. Representative Ackerman. Here. Representative Azzanaro.
Here.
Representative Bennett.
Here.
Representative Beer.
Here.
Representative Kassar. Here. Representative Fogarty. Here. Representative Giraldo.
Here.
Representative Handy. Representative Morgan. Representative Potter.
Present.
Representative Roberts.
Present.
Representative Speakman.
Present.
Okay.
Okay, I'll text him.
Chairman, we do have a quorum.
Thank you very much, Clerk. Okay, today we have one bill to be voted on for passage. It's House Bill 6014 relating to health and safety regarding the Office of State Medical Examiners. It's removing the sunset provision on the requirement that the Office of State Medical Examiners be responsible for multidisciplinary team review and drug-related overdose deaths. Do I have a movement for passage?
Motion
please?
to approve.
Motion to approve from Representative Azzanaro, second by Representative Bennett and Representative Giraldo. We're going to take a roll call vote.
Chairman Casey.
Yes.
First Vice Chair McLaughlin. Second Vice Chair Donovan.
Yes.
Representative Ackerman.
Yes.
Representative Azzanaro.
Yes.
Representative Bennett.
Yes.
Representative Beer.
Yes.
Representative Kassar.
Yes.
Representative Fogarty.
Yes.
Representative Giraldo.
Yes.
Representative Handy. Representative Morgan. Representative Potter.
Yes.
Representative Roberts.
Aye.
Could you repeat that, please? Representative Roberts?
Nay.
Thank you. Representative Speakman?
Yes.
Okay, Chairman. We have 11, Chairman, in favor.
Thank you, Clerk. House Bill 6014 has been moved out of the committee and will appear on the floor at some point in the near future. So we have the remaining House bills on the calendar. I will just read the bill numbers into the record. House Bill 5432, Senate Bill 383 as amended, House Bill 5849, House Bill 5850, House Bill 6015, House Bill 6019, House Bill 6020, House Bill 6047, House Bill 6078, House Bill 6079, House Bill 6129, and House Bill 5629. Can I have a motion to hold these bills for further study? So moved by Representative Ackerman, second by Vice Chair Donovan. We'll take a roll call vote, please.
Chairman Casey.
Yes.
First Vice Chair McLaughlin. Second Vice Chair Donovan.
Yes.
Representative Ackerman. Yes. Representative Bennett.
Yes.
Representative Beer.
Yes.
Representative Kassar.
Yes.
Representative Fogarty.
Yes.
Representative Giraldo.
Yes.
Representative Handy. Representative Morgan. Representative Potter.
Yes.
Representative Azzanaro.
Yes.
Representative Speakman.
Yes.
Representative Roberts.
Yes.
Okay, Chairman.
Thank you, committee members. Okay, we're going to take Representative Ackerman, who has two bills on the agenda this evening. The first bill we're going to do is House Bill 5629. That's the last item on your agenda, I believe. Representative Ackerman, you have the floor. Please go right ahead when you're ready.
Thank you so much, Chairman. Good evening, colleagues. House Bill 5629 would require that 911 system operators be trained in telecommunicated CPR. As you will hear tonight from witnesses, seconds, not minutes, are critical to saving someone in cardiac arrest. If a bystander or a family member, etc., were able to initiate CPR, the patient would stand a substantial better chance of survival. To do this, a dispatcher certified in telecommunicated CPR would coach the person online immediately until an actual rescue arrives, whether it's a fire department or an ambulance service. Each year, an estimated 350,000 sudden cardiac arrests occur in the United States outside of the hospital. With quick intervention, we will save lives. And I have some witnesses here today who could go into more detail for you.
Thank you, Representative Ackerman. Are there any questions from the committee for Representative Ackerman? I'm sorry, Deputy Whip Ackerman? Okay, there are no questions at this time. If we're ready for our first calling witness, okay. Well, while we're waiting for that, I will add to the testimony, if you don't mind. I myself am a first responder, member of the Woonsocket Fire Department. Immediate CPR is key to survival. The goal of immediate CPR is to keep the oxygenated blood going to the brain, and that is the number one factor. And actually, the protocol for the state of Rhode Island is that once you start CPR, it is required for us to start it and stay on scene for 30 minutes to do immediate CPR. The studies show that over the long-term survival rates, if you do bring back a patient with CPR, the immediate CPR is the best full recovery tool. So with that, I will go to the first caller. Unless anybody has a question for me, that's fine. Thank you, Representative Ackerman, for putting that bill in play. And we're going to have our first caller shortly. Hello, Mr. Lowell. Hello, this is Representative Casey, Chairman of the Health and Human Services Committee. How are you doing this evening?
I'm well, sir. How are you?
Good, sir. We have you before the committee on House Bill 5629 from Representative Ackerman regarding the 911 emergency training for CPR for the 911 operators. You have the floor. Please go ahead.
All right. So this bill affects all of us. I just want to explain. So currently in Rhode Island, if you do call 911, the call is routed to the town that you're calling from, for example, Cranston, and an ambulance is dispatched. And then oftentimes the 911 call taker will hang up after the call has been transferred. So meanwhile, the patient that's having a cardiac arrest lies on the floor, pulseless, until an ambulance arrives. And this is not the way that it should be happening and not the way it's done in our neighboring states. So when you call 911, you're expecting instructions on what to do. And this legislation now will mandate that 911 dispatcher will coach the caller through administering CPR, a process called emergency medical dispatch and telecommunicated CPR. So if you have a cardiac arrest in Rhode Island or at your house or a public space, your chance of survival in this state is terrible. But we can make it better by passing this bill. Bystander CPR, we know, has been proven to increase your chance of survival by 200%. In certain systems, such as in Seattle, where they do this, their survival is 62%. In Rhode Island, the best that we can tell, we may have a survival rate of 10%. The bystander CPR is the most powerful, evidence-based way to increase our chance of surviving an out-of-hospital cardiac arrest. And 4 out of 5 cardiac arrests happen at home, and therefore it's either ourselves or our loved ones who are likely to receive this benefit of bystander CPR. I'm an EMS medical director and an emergency physician, and I review a ton of cases. And one of the most common things that I find in out-of-hospital cardiac arrest is lack of bystander CPR. And I see that both in the run reports and I see that in the patients that happen in the hospital. And it's not just CPR that can be administered over the phone. There's bleeding control, childbirth, assisting victims of choking, and even recognition of a stroke. So passing this legislation directly gives these victims of cardiac arrest a better chance to walk out of the hospital. And there's not many accomplishments that I could think of, at least in my career, that will have a greater impact on survival. And we can make this change by passing this legislation. And the funny part is that Rhode Islanders need this, and most aren't even aware that this isn't happening. The Rhode Island Medical Society, American Heart Association, American College of Cardiology, American College of Emergency Physicians all support this legislation, and we hope that you do as well. At this point, I know you have a busy docket. I'd be happy to answer any questions if you have any.
Thank you, Joseph. We appreciate your testimony. Are there any questions from the committee at this time? Okay, one question from Representative Kassar.
Yeah, thanks so much for the testimony. Can you just talk a little bit about what's the timing for the uptake of this? Is this something that can instantly be done once this legislation is passed?
This is something that requires training and requires software. My understanding is that the software is in place at the 911 center after many years of upgrading all of their hardware, because my understanding is their systems were somewhat antiquated and couldn't support the software. It does take a while to implement training, and then there's ongoing training that occurs with this. That's why the effective date, I forget exactly what it was in the bill, but it's not set for later on in the year.
Got it. Okay, thank you.
Thank you,
My pleasure.
Thank you, Representative Kassar. Are there any other questions for the committee? Thank you for your testimony, Joseph. We're going to move on to our next witness, please. Hello, Dr. Cummings.
And couldn't support the software.
Yes, could you please turn down your device you're listening on?
Yes, I am.
Thank you very much. You are here with the House Health and Human Services Committee. We are here on House Bill 5629 regarding training for 911 operators in the administration or the instruction of CPR over the phone. You have the floor. Please go right ahead. If you could keep it a little bit brief. We did have some testimony from Mr. Lowell from the Rhode Island Chapter of American College of Emergency Physicians. But go right ahead, please.
Hello. My name is Catherine Cummings, and I'm the current president of the Rhode Island Medical Society. And first and foremost, we very much support this bill, and we hope that the committee will as well. This is a bill that we have been working on for quite some time. I am also an emergency medicine doctor, and I will also say the faster that you can start CPR, the better chance you have of survival, and that's what this is all about, saving lives. We have full support of both the training for the individuals as well as the software that is required to run this. That will make the most cost-effective use of the state's money. And again, this is very evidence-based. It is something that most Rhode Islanders think happened already and are surprised to find out that it doesn't. And for many, many good reasons, let's get behind it and make it happen. Thank you very much. I will keep it brief.
Thank you.
And I'll also answer any questions.
Thank you, Dr. Cummings. Are there any questions for the committee? Okay, we're going to move on to our next witness. Thank you, Dr. Cummings. Okay. Hello, Mr. Potvin.
Yes.
Yes, sir. This is Chairman Casey from the Health and Human Services Committee. We have you before us on 5629 regarding 911 operator training in the instruction of CPR over the phone. If you would,
Yes.
please go ahead with your testimony.
Excellent. Thank you. Thank you, Mr. Chairman and members of the committee. My name is Captain John Poppin of the East Providence Fire Department, where I serve as the Director of Emergency Medical Services. I'm also chairman of the Rhode Island Ambulance Service Advisory Board, and I serve on the Advocacy Committee of the American Heart Association. I'd like to thank Rep. Ackerman for her leadership on this critical issue. Each year, an estimated 350,000 sudden cardiac arrests occur in the United States in an out-of-hospital environment. Without quick intervention in the form of cardiopulmonary resuscitation, otherwise known as CPR, and defibrillation, death from sudden cardiac arrest is certain. Sadly, only about 10% of victims survive this dramatic event. Early bystander CPR approximately doubles the chances of survival of cardiac arrest. An effective way to ensure that CPR is provided quickly is for emergency telecommunicators or dispatchers to provide instant instructions over the phone. Telecommunicator CPR, or TCPR, allows bystander CPR to begin. It works by keeping the brain and heart alive until EMS arrives to provide defibrillation and other vital interventions. TCPR can assist the untrained caller as well as remind the CPR trained caller on how to provide high-quality CPR during a difficult and often frantic time. Simply put, TCPR saves lives. Telecommunicators are true first responders and are a critical link in the cardiac arrest chain of survival. Telecommunicator can be the difference between life and death. TCPR should be a standard of care for every 911 telecommunicator that provides dispatch instructions for medical emergencies. I'd like to thank the committee and Rep. Ackerman. I hope the committee will support House Bill 5629, and I'd like to thank you all for your time.
Thank you, Captain Potvin. We appreciate your service, and thank you for the testimony. Are there any questions for Captain Potvin? Thank you, sir. We're going to move on to our next testimony. Hello, Megan Tucker?
Yes.
Yes, this is Chairman Casey of the Health and Human Services Committee. We have you testifying on House Bill 5629 regarding 911 emergency telephone operators being trained in the process of instructing CPR over the phone. If you could go ahead with your testimony, we'd appreciate it.
Sure. Thank you, Mr. Chairman and members of the committee. My name is Megan Tucker, and I'm with the American Heart Association. I will be very brief because our wonderful medical professionals covered everything. The only thing I wanted to add was that in the FY20 budget, the General Assembly allocated $220,000 to train and certify all dispatchers in EMD. So you have actually already paid for this, and you also restricted 911 fees to fund 911 going forward. So I would like to thank, Deputy Whip Ackerman for her leadership on this critical issue. This bill will absolutely save lives, and we hope the committee will recommend passage. Thank you for your consideration.
Thank you, Megan. Are there any questions for our witness from the committee? Thank you, Megan. We're going to move on to our last caller testimony. Thank you. Yep. Hello, Mr. McAuliffe. This is Chairman Casey from the Health and Human Services Committee. We have you here on House Bill 5629 regarding the 911 emergency operators being trained in the instruction of CPR over the phone. If you could, please go ahead with your testimony.
Thank you, Mr. Chairman. I actually was testifying in favor of Representative Shawcross-Smith's bill on IEPs, 90-day referrals with physical therapists. I thought that's a bill. I'm sorry.
Okay, that's fine. We will transfer you. Would you like to say anything about the 911 bill while you're here?
Sure. I'll just be very quick because I know other people have spoken on much more eloquently than I have. Just that I represent the American Heart Association. They've worked and crafted this bill. It's a good piece of legislation. It'll save lives. It'll actually make the E911 response team even better and more qualified than they are already. So I ask the committee's support for it.
Thank you very much, Mr. McAuliffe. Are there any questions for Mr. McAuliffe? Okay, hearing none, we will close this bill for hearing. I will briefly announce that there was written testimony from the American College of Emergency Physicians who are in favor. Also, Dr. Joseph Lowell, who was our first witness, he also did written testimony in favor as well. And that will close the hearing on House Bill 5629. We will move on to Representative Ackerman's second bill, which I believe is House Bill 5432.
Thank you, Chairman. Nearly 500 Rhode Islanders will be diagnosed with colorectal cancer in 2021, and it will claim the lives of nearly 160 of them. But if caught early enough, the survival rate is 90%. Colorectal cancer is also the most preventable cancers, so we must eliminate the barriers for patients to get screenings. Financial concerns are one of the top barriers to colorectal cancer screenings. This bill, 5432, will help break those barriers and increase the survival rates significantly. I will also be looking, Chairman, to amend the title of this bill so that it matches Senator Goodwin's bill. She is the story of why we need early screenings for good outcomes, and I want to thank her for her advocacy on this.
Thank you, Representative Ackerman. And while we're here, I will put the second item on our calendar in play as well. That is Senate Bill 383 as amended. It is the Mary Ellen Goodwin Colorectal Cancer Screening Act. So that bill is also in play. The testimony will be the same. So we have two bills in play at this time. Thank you, Representative Ackerman. And we're going to go ahead to our first witness. Hello, Ms. Baker.
Yes, Chairman
Yes.
Casey.
How are you doing today?
I'm fine. How are you doing?
Very good. We have you here on the colorectal cancer screening bill by Representative Ackerman. If you will go ahead with your testimony.
All right. Thank you very much. Good evening, everyone. I want to thank you for the opportunity to provide testimony tonight on the importance of legislation to remove barriers to colorectal cancer screenings. I am a stage 3 colon cancer survivor, and I'm a part of the 14% that it was diagnosed at a later stage, and I was fortunate and blessed and graced enough to still hear that it was treatable and curable when I was diagnosed. I know from personal experience it is easy to procrastinate and put off the colonoscopy. For me, it was the preparation, which we know is not fun. We also think we're too busy with work, family, and friends. We never think that we're going to hear the words, "you have cancer." We sometimes also think if we don't talk about cancer, it won't happen. Well, that's not true, and I'm living proof of it. I want to also state that if there are financial barriers and expenses that occur for an exam before a colonoscopy, it is only a further incentive for people to put off an imperative exam that can save their lives. It is necessary to have legislation like H5432 and S383A to remove just one of the many incentives to delay the screening and to promote the importance of colonoscopies. I have no doubt if I had waited a few months longer, I probably would not be here as a survivor. Someone else would be sharing my story as an example of what not to do and reasons why financial access, education, and regular screenings are so important. But I am here, I am a survivor, and I know from experience what I went through with cancer is an experience that no one would want to endure. But luckily, colorectal cancer is extremely preventable with screening, and I can't emphasize that more. The colonoscopy saved my life. I was at the point that it had penetrated outside my colon, and my surgeon was concerned about one of my ovaries. And when she went in to perform the surgery, she had to take an ovary because she said it wasn't safe for it to stay in my body. So I am living proof that colonoscopies save lives. So if there has to be a diagnosis of colon cancer, let it be at the earliest stages as possible with the words treatable and curable. That comes with having access to diagnostic exams like the colonoscopy, quality health care, and education on colon cancer. This bill, H5432, would ensure that colonoscopies are not only limited to those with financial access, and I urge you to support it. And I thank you for listening to my story, and in solidarity, let's continue to fight against cancer.
Thank you, Barbara, for your personal testimony, and thank you for sharing your story with us. Are there any questions from the committee? Okay, we're going to move on to our next witness. Thank you, Mrs. Baker. Hello, Dr. Adrian.
Hello, and good
Yes.
evening.
Oh, it's Adrian, right?
No, it's Adrian.
Adrian. Okay, I got it this time. Thank you very much. This is Chairman Casey from the Health and Human Services Committee. We have you here regarding the Colorectal Screening Act. If you would go ahead with your testimony.
Thank you very much, Mr. Chairman, and thank you, committee, for allowing me to testify tonight. I'm Alan Adrian. I'm a gastroenterologist in Providence. I'm the governor of the American College of Gastroenterology, which means, like you, I've been elected by my peers to represent them and our patients. I'm also a past president of the Rhode Island Medical Society, and I speak in strong support of this very important bill. Colon cancer is the second most common cause of cancer death in the United States, second only to lung cancer, and it's caught early. It's 80% curable, but if not caught early, 50% of people who are diagnosed with it will die. The best test for colon cancer, and the best way to prevent colon cancer is with colonoscopy, but for various reasons, not everyone is agreeable to have a colonoscopy. Absent that, the best thing to do is to screen for colon cancer, which, while it doesn't prevent colonoscopy, it can catch it early and at a curable stage. In Rhode Island this year alone, about 500 people will be diagnosed with colon cancer, and about 150 will die of it. And if caught early, many of those deaths are preventable. Anything that puts a roadblock in the way of preventing colon cancer deaths costs lives in Rhode Island. When people choose to have a stool-based test for colon cancer, the Affordable Care Act requires that colon cancer screening be covered without a copay or deductible. But once they have one of those tests, they've used that coverage, and now, by that law, the subsequent colonoscopy is considered diagnostic rather than screening and can be subject to copay or deductible. This means that in an average risk 50-year-old person who has a positive test, the entire cost will fall to them, and they will often defer the test in order to avoid that cost because it's not negligible. This, in the end, results in delay of diagnosis and can lead to unnecessary advanced disease and death. The goal of this legislation is to prevent roadblocks from the prevention of colon cancer deaths. What we ask is that when a stool-based test is positive, that colon cancer screen, or that it be considered a two-tier test, so that the colonoscopy is really considered part of a two-tiered screening test and is covered so that cancer is caught early. It doesn't make a lot of sense to do a test to screen people and then not do the test that's required after finding a positive test. It doesn't save any lives. It costs the system without saving the system anything. So this test can prevent unnecessary suffering and death, and in the long run actually save money, because studies have shown that for every $3 spent in screening, for every dollar spent in screening, $3 are saved on the treatment of colon cancer, in addition to, obviously, the decrease in suffering and death as a result of colon cancer. So this, to me, is a no-brainer. It makes sense to prevent preventable deaths, and this is actually already, the major insurer in Rhode Island is already covering these tests because they know it's the right thing to do. It's mainly out-of-state insurance companies who are more beholden to their shareholders than they are to our citizens that are not doing this. So I really am hoping that this year we can get this passed and prevent unnecessary deaths in Rhode Island. And I thank you for your attention. And is there any questions for me?
Thank you, Doctor. Are there any questions for Dr. Adrain? Okay, hearing none, we are going to move on to our next witness. Thank you, Dr. Adrain. Hello, Dr. Shah. This is Chairman Casey of the Health and Human Services Committee. We have you here testifying on House Bill 5432. If you would go right ahead, please.
Thank you. Thank you, Chairman Casey. My name is Samir Shah. I'm clinical professor of medicine at Brown University and chief of GI at the Miriam Hospital. I'm in practice with Dr. Alan Adrian, who just testified. I want to lend my strong support to the House Bill 5432 and the Senate Sister Bill 383A. You've already heard about this. In addition to being a gastroenterologist, I am fortunate to serve President-elect of the American College of Gastroenterology, past president of the Digestive Disease National Coalition. What's clear is that colon cancer can work. And not only can we diagnose colon cancer early stage when it's treatable and curable, we can prevent colon cancer by removing polyps. You've already heard the statistics. You've already heard that it's effective, so that not does it save lives, but by spending money on screening, we're saving a lot more down the line, not to mention the suffering. So everything's been said. I'll just emphasize the importance of this bill. We see patients every day who have delayed their testing.
I'm going to hand over to the hospital. I'm sorry, sir. Go ahead. Okay, sir. Doctor, you're breaking in and out a little bit. Are you traveling right now?
No, I'm...
Okay. If you want, we will hang up with you and go to our next witness, and I'll call you back. Maybe the connection will be better.
Okay.
All right, thank you. Okay. Hello, Corey Chandler.
Hello, this is Chloe.
Hi, Corey. This is Chairman Casey from the Health and Human Services Committee. You're here on House Bill 5432. If you would go ahead with your testimony.
Hi, thank you so much, Chairman Casey, and thank you to the rest of the committee for allowing me to testify this evening. My name is Corey Chandler. I'm the Government Relations Director for the American Cancer Society Cancer Action Network here in Rhode Island. As many of you probably already know, ACSCAN supports evidence-based policy and legislative solutions that are designed to eliminate cancer as a major health problem. First, I just wanted to thank Deputy Whip Ackerman for championing this bill in this chamber over the past 3 years. I'll be brief, as you've already heard testimony that explains this bill well tonight, and I know Dr. Shaw will be joining you again. I've also submitted written testimony that demonstrates strong support from ACSCAN and 17 other organizations for H 5432 and Senate 383A. Just wanted to thank you all for taking the time to hear from so many Rhode Islanders and ACSCAN volunteers about this legislation. We had the opportunity to meet with many of you during our Cancer Action Week, and we are also really thankful to have Rep. Baginski speak at the kickoff for the Cancer Action Week on this legislation as well. So this bill has been a priority for us. It's been introduced in the House chamber the past 3 years, but this year I did just want to point out that it holds particular significance, given the impact that that COVID-19 has had on colorectal cancer screenings. So when you actually compare the first quarter of 2020 to the first quarter of 2019, we saw a 90% decline in colonoscopies and biopsies. The National Cancer Institute has actually come out and said that they expect to see 4,500 excess deaths due to this decline in screening. And that's incredibly concerning to us because we already know that nearly 60% of the deaths from colorectal cancer last year were due to non-screening. Finally, I did just want to note that our current American Cancer Society guidelines do indicate that a follow-up colonoscopy is an integral component of the screening process. Thank you so much for your time. I'm happy to take any questions if you have them.
Thank you, Corey. Are there any questions from the committee for our witness? Okay, hearing none, we're going to move on. Thank you, Corey.
Thank you.
Hello, Dr. Shah.
Hi, Chairman Casey. Can you hear me okay?
Yes, I can hear you okay. Go right ahead. You can go ahead and start from the beginning. I don't want to assume that we caught everything, so go right ahead.
Great. Well, thank you, first of all, to you and the committee for letting me testify. My name is Samir Shah. I'm clinical professor of medicine at chief of gastroenterology at the Miriam Hospital. I also have the honor of serving as president-elect of the American College of Gastroenterology. I've listened to the previous testimony, and so I'll be brief. I want to emphasize that colon cancer is preventable, not only curable if detected early, but preventable by colonoscopy and removing polyps. Too many times we see patients waiting or delaying. You've heard from Dr. Adrian that $3 we spent on prevention, we $3 to $4 on the other end. So not only is it the right thing to do, it saves money and it saves lives. So on behalf of the people in Rhode Island, the patients we take care of, the American College of Gastroenterology, and the Disease Network Coalition, I'm happy to testify strongly in favor of both House versions of this bill, and I'm happy to answer any questions.
Thank you, Doctor. Are there any questions for Dr. Shah? All right, thank you, sir. That's going to close the hearing on House Bill 5432 and Senate Bill 383. Okay, we are next going to move on to, I'm sorry, before I do that, I just want to, for the record, read the people who have submitted written testimony. Every person that I read off, every organization that I read off is in favor of this legislation. The Rhode Island Academy of Physician Assistants, Robert J. Ackermann, PA-C, Jordan Goyette, Joseph Dziobek, University Gastrointestinology, the YWCA of Rhode Island, the Roger Williams Cancer Center, Rhode Island Medical Society, Rhode Island Healthcare Association, Gastroenterology Associates, Inc., RI Academy of Physician Assistants, Rhode Island Health Center Association, Rhode Island Public Health Institute, the Hospital Association of Rhode Island, the Brown Cancer Center, Charter Care, Fight Colorectal Cancer Organization, Protect Our Healthcare Rhode Island Organization, American College of Gastroenterology, the Rhode Island Academy of Family Physicians, AARP of Rhode Island, Protect Our Healthcare Coalition, the Office of the Health Commissioner, and Rhode Island Blue Cross and Blue Shield. That will do it. Are there any comments or questions from the committee before I close the hearing? Thank you. That will close the hearing on House Bill 5432 and Senate Bill 383. We're now going to move on to Representative Camille Vella Wilkinson for House Bill 6020. 60220 is to start a legislative commission to study Rhode Island's payment and reimbursement for hospital-acquired conditions and healthcare-associated infections, and providing recommendations to establish and clarify the state's policies. Representative Vella Wilkinson, please go ahead with your testimony.
Thank you very much, Mr. Chairman and members of the committee. I want to start off by telling you I do not have a background in healthcare. It's off. Oh, okay, thank you so much. I don't have a background in healthcare, but what I do have is a very inquisitive mind and a ravenous hunger for information. After being in office 6 years in the city council and then coming up here to the State House, I had the opportunity to speak to quite a number of my constituents with regards to Medicaid and Medicare. And what I heard from them had me exceptionally concerned, so much so that I put in the bill that's in front of you today. So I want to start off by telling you that a great deal of the information I'm going to be sharing with you today comes from CMS, which is the Center for Medicare and Medicaid Services, and also from the EOHHS website. In particular, a study that EOHHS had commissioned by Xerox. And the study that Xerox, for their data set, included 139,743 inpatient stays. So I want to draw the attention of the committee members here to a handout that hopefully you've all received by now. And it has a list of the Rhode Island hospitals, and then there's a graph on the opposite side of the page showing 2015 up to 2021. And what it's telling you is that any of the blocks that say yes means that those hospitals' payments were reduced by 1% because of the high rates of complications. And in particular, we're talking about HACs as well as HAIs. Now, the study focused on what's called a PPR, which is a potentially preventable readmission. So that if an individual has been released from the hospital and then they are readmitted in 30 days or less, when Medicaid is looking at the reimbursement to the hospital, they check to see if it was a potentially preventable readmission, and then they go according to certain criteria, if it was preventable, whether or not the hospital is going to get the full reimbursement for the services that they provided. The risk of a PPR typically peaks 2 days after discharge. And in the data set provided by Xerox, the PPRs represent a total of 7% of payments. That's 10% of hospital days, for total payments of 55,815 stays, which comes to $47 million. Now, when you look at what the Rhode Island state budget is, or at least what it was over the last 2 years, you might not blink at the idea of $47 million. I mean, not all readmissions are preventable, but a 10% reduction of what we do have that's preventable, just a 10% reduction would generate a savings of $5.2 million in payments to the hospitals, plus the associated payments to physicians and other healthcare providers, as well as representing benefit savings to the patients. I'm going to say that number again because it's important, $5.2 million. Now, the study focused on Medicaid patients, which, as you know, is a federal program. And the feds put in a lot of guidance with regards to the policy of treating the patients and discharging the patients. And they also look very closely at the reimbursements. So one of our Rhode Island hospitals, and I'm not going to tell you which one, but one of our Rhode Island hospitals was fined in 2019 $440,000 because when the patient was readmitted, it was found to be a PPR, which is potentially preventable, and that amount of money is what their reimbursements by the feds was reduced by, $440,000. Now, if the hospitals, and as I said, you can see the hospitals in that sheet, if the hospitals are playing fast and loose with the federal programs, what do you think they're doing with the most vulnerable in the state of Rhode Island? What are they doing to the Medicare patients? If Medicaid is fining $440,000, if the state was not asleep on its feet, what would we be able to recoup with regards to payments of our constituents who had potentially preventable readmissions? I don't know what the amount would be. I will tell you the truth. I don't know what it would be. But what I do know is that according to the Xerox findings, 10% of a reduction would equal $5.2 million in savings. And Xerox went on to give a list after they did a full investigation of what our policies and procedures are in the state of Rhode Island. They came up with a list of at least 11 different actions and policy recommendations that if we instituted in our state would save us even more than the $5.2 million. So I'm going to go back to what I initially said. I don't have a background in healthcare. And I've worked on budgets before. I worked on budgets for the Department of Defense when I was in the Navy. I was the chair of the Finance Committee when I was on the City Council in Warwick, and I'm on your Finance Committee here at the State House. I think this is too important to push aside. And I'm going to tell you again, this study is featured on the website for EOHHS, but I could not find any linked documents that showed where they took any of the recommendations from the study that they paid for, or excuse me, for the study that our constituents paid for. I don't see anything where they took up action on any of those 11 recommendations. And instead, the hospitals, the Rhode Island hospitals, continue to be in the bottom quartile nationwide. Why are we in the bottom 25% of hospitals nationwide when right across the border in the state of Massachusetts, they're ranked 4th in the nation? So we're in the bottom 4th and they're 4th on top. Why? And I'll tell you why. If you look at the Medicaid and Medicare policies for the state of Massachusetts, everything is laid out, full transparency, so that the insurance companies know exactly what's going to be paid for and what the state of Massachusetts is not going to allow a payment on. And so their Medicaid and Medicare programs are significantly tighter than the state of Rhode Island. Ladies and gentlemen, we need to do this for our people, not only for Medicaid and Medicare as a program, but I think that our constituents deserve better than to be released from the hospital, to come back again, and then to have their benefits drained off because the hospital didn't do the right thing by them in the first place. It's in your hands. I think we need this study. I'm sure that we need this study. And I look forward to hearing some favorable comments from the committee. Thank you, Mr. Chairman.
Thank you, Representative. Are there any questions for the bill sponsor? Representative Fogarty.
Thank you, Chairwoman Bella Wilkinson. I totally agree with your assessment of this. That's why I signed on to this bill. This could be we have to actually get oversight involved with this, because actually there has been a study that's been done and we don't, as you say, you haven't seen anything reviewed. So I think that we have to get serious about this. Our hospitals are having issues. That's why we're seeing this big merger going through. But we can't let things go on as they are. I was a hospital administrator by degree. There's a lot that hospitals can do about this. I haven't worked in a hospital in a very long period of time. But they have to tighten their budgets and they have to tighten their belts and also look at what they're doing for patient care. I understand that's what they're trying to do, but try to get patients out of the hospitals, but then you send them home. I also worked for a home health care agency, so I saw the other end of it when they come out and they come out too early and then they have to go back in. And again, like you pointed out, the cost that the patients have to suffer is not right. So I totally am on board with this type of a commission. And again, I think oversight should look at what's not happened already with the past study, but continue on. We've got to be serious about this. It could save the state a lot of money and these hospitals a lot of money from being in the red. Thank you.
Thank you very much, Chairwoman.
And I just want to point out one thing here, that South County Hospital, where I'm from, is not marked as yes in any of the blocks. So I think that they fared well. So kudos to South County Hospital.
Thank you, Chairwoman. I have the highest respect and regard for your experience, and I would fully and enthusiastically embrace your participation in this study group if we're given permission to go forward.
Absolutely.
Thank you.
Yes.
Thank you. Representative Kassar and then Rep. Giraldo.
Thank you, Chair Bella Wilkinson. This is very important legislation. And, one of the things that strikes me is the overlap of time is when the programs of meaningful use and pay for performance were engaged from CMS. So CMS programming, and I think that 2015 onward, really that 1% penalty was part of CMS's meaningful use program. And there are two elements to it that I'm concerned with. One is, yes, the delivery of services, But the other is documentation. I worked on the software side for a while when meaningful use was happening, and sometimes hospitals would be dinged as a result of not necessarily that they didn't do the work, but they didn't document it in their paperwork. So I think we have two pieces, right? We have the services as well as the systems that support the services, and making sure that our hospitals are including both of those. So I'd just love to make sure that the commission engages on both of those issues.
Absolutely. Thank you for your comments, Representative. And I will tell you, just by virtue of the fact that there's such a lack of transparency on the website for CMS and trying to see even what their policy for reimbursement is, I wasn't able to see it.
Yeah,
Whereas Massachusetts, I was just poking around, it just popped up.
Yeah, we can do
So,
better.
yes, thank you very much.
Thank you, Representative. Representative Giraldo, go ahead.
Thank you, Mr. Chairman. And thank you for this information, Chairwoman. $5.2 million is a lot of money and can absolutely go a long way. And I appreciate your push for transparency and accountability and support the idea of a commission. I actually just have one question around PPRs, potentially preventable readmissions. Can you provide a real life example of what a PPR might actually look like for myself as I'm trying to visualize this, and for anyone who may be in the public listening? What is an example of what a PPR could look like?
I do have it. Let's see. Unfortunately, Representative, I did not bring that sheet with me, but it's very extensive, and I'll make sure that that information is provided to all the members of the committee, because it also talks about comorbidity effects on the PPR. So I want to make sure that when I give you the information, that it's not skewed, so that you can see everything that they take into account. But I will make sure that you have that.
Completely understood, thank you. And just an example would, am I correct in stating that an example would be someone goes to the hospital for, let's say, an operation, and it's not treated, well, they're let go too early, as I think someone else mentioned, and it ends up getting, the operation ends up getting infected, and they have to be returned to the hospital. That would be an example of a PPR, most likely. Am I correct?
Yes, that's exactly correct. That falls under the category of an HAI, healthcare-acquired infection, as opposed to a hospital-acquired condition. But you are exactly correct. They are both PPRs.
Thank you. It just helps me visualize the situations that are being discussed. Appreciate it.
Thank you.
Thank you for that explanation. Are there any other questions? Representative Fogarty.
No, just to add to that, because the hospitals are under the pressure because they have a DRG, the diagnostic-related group that they have to meet, and there's a certain criteria of days, and Dave Bennett could probably chime in on this, that they're trying to push these patients to get out because that's their payment day schedule. So that's why they're trying to get them out sooner. And you have situations like that, or you have somebody who has some type of an orthopedic surgery, but they want to get them out of the hospital, but then they're a fall risk, and they fall, and then there's another complication from that. You know, that's just another very basic example of it.
Thank you, Chairwoman.
It's the fighting of the DRG, and then getting them out of the hospital, and then you got to make sure that that they're prepared for it, and especially these patients who are on Medicare and Medicaid. Thank you.
I'll make sure that you also have the definitions list, because I found that healthcare has more acronyms than even the Department of Defense does.
Isn't that the truth? Are there any other questions? Representative Bennett has a comment.
Answering your question, staph is what usually comes with a lot of these infections. You have MRSA, you have VRE, but the staph is everywhere. It's in your nose, and when you have surgery, especially orthopedic surgery, you could have a reaction to the staples, you could have a reaction to the sutures, but the infection itself is deadly. It can kill you. Staph can kill you. It can also leave your limb or whatever you had operated on useless after you have this. The reason the hospitals want to push you out so fast is because of the insurance companies. Insurance companies will only keep you, pay the hospital so long, and even when you got a hospital that's not super busy, they still try to get you out. I mean, there's women that have babies and they're pushed out the next day, you know, and they usually get infections from, you know, endometriosis or something of that nature. I'm not a GYN person, but, you know, it's complicated. And to say, you know, that you got to go from the hospital before you're ready is a shame. And that you can't blame the hospitals for that. You got to blame the insurance companies for that. You know, the reimbursement rates, the whole 9 yards. But I think this is a good bill. It's interesting.
Thank you very much, Chairman.
Thank you, Representative Bennett. Are there any other comments or questions? Thank you, Representative Wilkinson.
Thank you, Chairman.
Okay. That will close the hearing on House Bill 6020. We do have one person, the Hospital Association of Rhode Island, who is in favor of this legislation. That was the only written testimony as well. So that will close House Bill 6020. Representative Tanzi, are you ready to go? Okay, we're going to have Representative Tanzi next. Her bill is House Bill 6047. This is an act relating to business and professionals regarding pharmacies. While she's getting ready, I will say that we have written testimony from Kendra Walsh of URI. Excuse me. She is in favor of the bill. The American Lung Association is in favor of the bill. The Rhode Island Department of Health is in favor of the bill, Dr. Alexander Scott. And Representative Tanzi, you will go ahead with House Bill 6047, and I will turn this hearing over to Vice Chair Donovan.
Thank you, Chair and members of the committee. This bill would authorize a licensed pharmacist who successfully completes a course on tobacco cessation therapy to prescribe and dispense tobacco cessation drugs to a qualified patient pursuant to rules adopted by the Board of Pharmacy. So in a nutshell, that's what it does. This also, just to give you a couple of the key components, this would be only to patients 18 or older, and they would agree to be a part of a structured tobacco cessation program and subject to an initial evaluation. So the pharmacist would sit down and have a discussion and an evaluation of the patient. And then they would be educated on any interactions, any nicotine overdose warning signs, depending upon which medicine they were getting. Some are nicotine replacement and others are a different type of drug. And then they would follow, the pharmacist would, the United States Department of Health and Human Services clinical practice guideline. This has been in effect since 2008, so these practices have been approved by the federal government since then. And then, of course, the physician, the pharmacist would then, within 5 days, would alert the primary care physician of this patient if that patient has one. So this bill, or this procedure, is allowed currently in 14 states. I know that in front of you there's a handout that's from 2018 that says far fewer than that, but there's been a lot of momentum around this across the nation. In fact, I have printed out the map. It's not just the coasts. In fact, it's predominantly the middle of the country that has allowed for this to happen. Currently 14 states. And the first state did so in 2014. So that's 17 years of being tried and true. Again, the feds approved the procedure back in 2008. And 17 years of proven effectiveness and harm reduction. And cigarette smoking is estimated to cause approximately 480,000 deaths a year, preventable deaths. And this is estimated to cost, smoking-related illnesses cost the nation more than $300 billion a year. Both of these numbers, again, are 2018 numbers. and are striking nonetheless. We can only guess that the problem is worse. And let's be honest, it's more than just tobacco that is the problem. We're also facing a tremendous issue around the use of vaping and e-cigarettes, and nicotine addiction is skyrocketing because of the e-cigarettes. And more and younger people are being impacted because of this nicotine delivery system, the electronic nicotine delivery systems. So the sooner that we can get the people who are using them inexpensive, easily accessible remedies to treat their nicotine addiction, the better the outcomes will be for our constituents. And you know, there's all kinds of data that's available on this. I'm not sure who's going to testify after me, but you know, there are surveys that say that 40% of college students use vaping devices. I don't even delve into what the youth are using because this legislation only impacts people 18 and older. But you know, we think we have a problem, you know, now. Just wait as these people, you know, age and continue with their addictions. So I think that it's really important that we act on this now. So why a pharmacist in addition to the physicians? Well, first of all, pharmacists are physicians, they are doctors, but they serve the community in a far more accessible way. 91% of residents in the US live within 5 miles of a pharmacy. Not everyone has such easy access to their physician. This is about affordable access to the appropriate means to quit. To quit smoking and vaping when the person is ready to quit. Timing is everything when it comes to breaking the habit. It really is critical. Waiting for a doctor's appointment, even just waiting a day or two, can mean a lost opportunity. That person may decide at that point that it isn't the time for them. There's all kinds of reasons. And as a former smoker, someone who smoked myself for 18 years, I can tell you there's always a reason why now is not the time. And when you get to that point, when you recognize it is critical that you act on that. So there are some nicotine replacement therapies that are available over the counter, and it can be costly, very costly without a prescription. So this bill would allow pharmacists to give access to patients with insurance, which is 96% of Rhode Islanders, receive this life-saving medicine without concern of the cost, which can be upwards of $600 a year. And just as important, this would give patients access to prescription drugs that have been successful and used for long periods of time, for years with no significant side effects. Physicians are highly trained medical doctors who are easily accessible and trusted by their patients. I also want to remind the committee that we just overwhelmingly passed a bill on the House floor allowing pharmacists to prescribe birth control. And this is yet another opportunity to help our constituents access the health care they need when they need it. And I'm happy to answer any questions if anyone has any.
Thank you, Representative Tansey. Representative Bennett has a question.
Besides the fee for the product, does the pharmacist receive any compensation?
No.
So they'd be doing this as a public service?
Exactly. Just like when they provide a vaccine,
Right.
it's part of the screening process for when they prescribe that.
Thank you.
And I believe there will be a pharmacist or two speaking after who can confirm that. Indeed.
Are there any, yes, Representative Fogarty.
No, thank you, Rep. Tansey. I truly support this bill. You're right. It's that time when the person has that spark that they want to stop. And if they can go to their pharmacist versus trying to get in to see a physician, you can walk right into a pharmacy. Most of them have consultation areas that they can go in. And a pharmacist, like you said, we passed that bill about, you know, oral contraceptives. This is just so easy and so smart. And I'm very happy that you put this bill in. Thank you.
Thank you. And thank you for being a co-sponsor.
Any other questions from the committee? Okay, we'll go to our first caller. Okay. Dr. Correa?
Yes, hello.
Hello, this is Vice Chair Donovan. You are testifying, and you may proceed.
Thank you very much, Chairman and the committee there. My name is Dr. Ken Correa. I'm a clinical pharmacist representing the Rhode Island Pharmacist Association. And I just wanted to speak briefly in our support for this bill that would allow pharmacists to use the training that they have to help our patients that are battling their addiction to tobacco. As we heard tonight earlier, they talked about kind of colorectal cancer as being the second leading cause of cancer death. Unfortunately, lung cancer is our primary cause of death among cancers. And even outside of cancer, asthma, COPD, and other smoking-related conditions are a major driver of morbidity and mortality in our state. And currently, the Affordable Care Act requires insurance companies to cover these services for patients, both education and prescriptions for patients when they get it prescribed to them. But one of the biggest barriers for patients is actually making that doctor's visit or making sure that the doctor or their prescriber actually addresses and then recommends a product for them to help them quit. I don't know how many of the committee members are former smokers, but quitting smoking is difficult and it takes multiple attempts. And having an expert that is trained on the use of the medications and is at the point of care that is accessible to them and is there when the patient is ready and willing to quit is important to making sure that patients do well. Currently, pharmacists in our state are all trained to counsel and to educate patients on nicotine replacement products and the prescription type medications that are recommended by the national guidelines. And this bill would allow our most accessible healthcare providers to be able to provide that service to patients, and it would remove a barrier right now of requiring a prescription in order to get that service covered. So we have patients every day that walk into pharmacies to buy nicotine patches or other products, but it's expensive and it's a barrier. And currently, in order to get it covered by an insurance company, they end up having to call and make an appointment with their provider, which can delay and cause complications and by the time the patient does get a hold of their provider, they may not necessarily be ready or willing to quit at that moment. So making sure that pharmacists can provide services for tobacco cessation to patients at the point of care when needed is important. I myself currently work in a primary care office. I'm already providing their services under a collaborative practice agreement, but the restriction of collaborative practice requires that the patients be actively engaged with my practice, for example. So they have to see one of the doctors that I work with in order for me to be able to provide this service. And so even earlier today, I met with a woman who was ready and willing to quit. She is a patient in our practice, and so I was able to prescribe this for her. But her husband, unfortunately, uses a different provider and actually doesn't have a primary care doctor. And so I wasn't able to help him because he would fall outside of the scope of collaborative care practice. And so he wasn't able to get the treatment. And even though we know that patients, and when the entire family or household is treated at the same time and they're all going through the quit attempt at the same time, do better, I wasn't able to help him with his goals of quitting smoking at that moment. So I had to refer him back to a provider who hopefully can provide him that service. This bill would allow for not only the pharmacists that are at the local community pharmacies that already have these relationships with patients being able to engage them in quitting smoking, but it would also allow those of us that are integrated and work in hospitals and outpatient settings and primary care offices to engage the other patients that are part of the family that are also smoking to make sure that the patients that we're actively working with towards their goal of quitting smoking would do better. Rhode Island would be the 15th state to allow this. There are 14 other states in the country that already allow this, New Hampshire and Maine among them, in New England. So Rhode Island would definitely not be unique. This is not a new idea. And the idea would be to kind of expand access and allow pharmacists to be able to prescribe evidence-based medicine to patients when they need it at the point of care. And the medicines that we're talking about that are part of this, that would be included, are the medicines that are recommended by the guidelines, stuff that's nicotine replacement patches, lozenges, gum, bupropion, varenicline, so Chantix, medications that have been on the market for over 20 years, have lots of safety data. We know that these medications can be easily prescribed based on patient interview. They don't need blood work or physicals or anything else that would be a barrier to prescribing them. The vast majority of the time, these medications can easily be prescribed and managed by someone just through a patient interview and history taking. and it doesn't require complicated medical skills in order to be able to decide whether or not someone is a candidate for one of these products. So on behalf of the association and myself personally, I would ask the committee to please be in favor of this bill. And if you guys have any questions or comments, I'd be more than happy to hear them.
Thank you, Dr. Correa. Are there any questions for this witness? Okay. Well, thank you for your testimony, and we'll go on to the next caller. You're welcome. Hello, Anita. This is Vice Chair Donovan. You're testifying on Bill number 6047. You may proceed.
Thank you. Thank you, Chairperson and members of the committee. I am a pharmacist in Rhode Island, practicing since 1998, but I am addressing you tonight as a former cigarette smoker. I started smoking when I was about 14 years old. It was just occasional dabbling until about the age of 16, when it became more regular. By college, I was smoking up to a pack a day, and I was very addicted to nicotine. I wanted desperately to quit smoking in pharmacy school because it was definitely frowned upon by faculty and my fellow PharmD students. I was extremely ashamed of my addiction, but by the end of the class each day, I was suffering so much from withdrawal symptoms that I would race to my car, often turning down opportunities to socialize with my peers or participate in extracurricular activities because I wanted that cigarette so badly. I was willing to sacrifice valuable experiences to have one. The reason this is relevant to this legislation is that I never told my primary care doctor that I smoked. And as importantly, he never asked. He was also my parents' doctor, and we are, quote, an educated family, so I'm quite certain he just assumed I was smart enough not to have the disease of addiction, even though it's present in about 20 to 25% of the population and not linked to education level. I suffered greatly with withdrawal every time I tried to quit, which was upwards of 10 to 20 times during college. The truth is that if I could have gone to a pharmacist, especially a pharmacist who was in a town far away from my South Kingstown parents, to get a prescription, I'm 100% sure I would have. As a college student, I often didn't have the money up front to buy patches and gum over the counter, and when I did, it wasn't what I wanted to spend money on because I was short-sighted, as 20-something-year-olds often are. To this day, when I go to see any doctor, including my primary care and GYN, upwards of 90% of the time, the medical assistant absently says, "You never smoked, did you?" with a tone in their voice or a dismissive laugh about how ridiculous it is to even ask a professor of pharmacy that question. Every once in a blue moon, a medical person will ask, "Do you smoke or have you ever smoked?" in a manner that welcomes honesty. So then I do share my story. Otherwise, I don't, because I'm still ashamed of my history of smoking. I really admire my colleagues in primary and specialty care, and I strongly suspect they teach their medical assistants to ask open-ended questions, so this is not a criticism of them. It is a desire to expand options available to people suffering with the disease of addiction, especially young people who may feel stuck with their parent's doctor until the age of 25 when they have their own insurance. All pharmacists are trained in tobacco cessation therapy. I have personally taught every single one of them that walks across the stage at URI since 2010, and they have extensive training, including graded simulation activities with patients to provide smoking cessation counseling and select evidence-based and individualized treatment. The time is now to pass this legislation. Please vote it out of committee tonight. Don't hold it for further study. We've studied this for the past 25 years, and the data is clear. I think the pandemic has proven pharmacists are ready, willing, and able to provide care. allow us to expand choice and easy 24/7 access to these low-risk prescriptions for the disease of nicotine addiction. Thank you.
Thank you for sharing your story, Anita. Are there any questions for this witness? No? All right. Thank you for your testimony.
Thank you.
And that concludes the call-in testimony. Are there any other questions? Okay. All right, that closes the hearing for 6047. We'll move on to bill number 6129, and by Representative Shallcross-Smith. Are you ready, Representative?
Yes, I am.
Okay.
Good evening. Good evening, Chairwoman and committee members. Thank you for the opportunity to present this evening a 6129 entitled A Physical Therapist. This bill seeks to amend language in the Physical Therapist Enabling Act to help provide a continuum of services for special education students without interruption or delay due to current requirements for a prescription after a 90-day service.
We just lost the audio. Okay.
How's that? They come back?
You're back, yes.
Excellent. In the state of Rhode Island, physical therapists have access, meaning a physical therapist can provide services without referral. Yet, current state law requires physical therapists to obtain a referral from a physician after 90 days of service. The school-based physical therapy services provided in a school setting are prescribed through the students through an individual plan IEP set by interprofessionals collaboration team, which includes a physician. Physical therapists that deliver services according to the IEP or IFSP should be exempt from the 90-day referral because the student is entitled to these services by law according to the Department of Education, and such service plans are written on a one-year time frame. We have two people testifying this evening, gentlemen from the May 4th Group and a Physical Therapist Association. Thank you for the opportunity.
Thank you. Do we have any questions for Representative Shallcross-Smith? Okay, before we go on to the verbal testimony, we have written testimony in favor by the American Physical Therapy Association and Natalie N. Mason, physical therapist, in favor. Okay, first caller. Okay. Mr. McAuliffe?
Yes.
Yes, this is Vice Chair Donovan. You're testifying on House Bill 6129. You may proceed.
Thank you very much. I appreciate your time and your commitment tonight to try to get all these bills done on a timely basis. So I'll be fairly quick. I'm Rick McAuliffe. I represent the Rhode Island Physical Therapists Association. We represent all the physical therapists in the state, and they number close to 1,000 physical therapists who work on a variety of different things.
Excuse me. Yeah. Could you turn your audio off, please, Mr. McAuliffe? Turn.
I don't have any audio on.
No? Okay, thank you.
Okay, is that better? Yeah, I don't have any audio on. I'm sorry. Well, let me just be quick then. Again, Rick McAuliffe with the American Physical Therapist Association of Rhode Island. We represent close to 1,000 physical therapists, all the physical therapists in Rhode Island. And this is a bill that's very important to us, and you'll hear from a physical therapist who actually works in a school setting after me. We asked for this legislation, and it's I think our second or third attempt to get this passed. The legislation is very simple. At the beginning of a school year, as you and members of the committee all know, there are a number of children in our school system that require IEPs, individual education plans. And some of those individual education plans require physical therapy. And the way it works is once they have the physical therapy and they talk to the physical therapist as part of that initial group with all the other education experts, that student will have physical therapy various times during the week, the month, and so forth. Unfortunately, the way it works now is after 90 days, to continue physical therapy for the student, you have to go back and get a referral from a doctor. The initial one, you don't need a referral, but you need one every 3 months, every 90 days. That is cumbersome for both the school department, the physical therapist who's putting the work in, and actually the family themselves. And sometimes with the doctor's referral, it could take weeks until they refer it again to get them allowed to do physical therapy. So what this bill would do is it would waive the 90-day period, and basically it would go school year to school year. Many of the children we're talking about have permanent disabilities that require physical therapy throughout the year and candidly throughout their life. And so rather than every 90 days having a referral, what this bill would allow is for an IEP when they start at the beginning of the year, before the school year starts. The physical therapist is already included in that. And then once they've been authorized for it, they will continue the physical therapy through the year, obviously reporting and everything that needs to be done on progress and how they're feeling. But then they wouldn't have to get it renewed until the following year when the IEP is updated, renewed, and so forth. Right now, unfortunately, every 3 months they need to do that. So we think this is a good piece of legislation that will help both the children in the school system, help the administrators, obviously help the physical therapists who are working directly with them, and it would get rid of some of the bureaucracy and continued cumbersome work of calling a doctor just to get it renewed every 30 days. And that's why we asked for your support on this piece of legislation.
Thank you, Mr. McAuliffe. Are there any questions for this witness? Okay, thank you for your testimony.
I appreciate it. Thank you very much for your time.
You're welcome. The next caller is Natalie Mason. Hello, Natalie. This is Vice Chair Donovan. You're testifying on Bill number 6129. You may proceed.
Good evening. Thank you. I am a school-based physical therapist, currently working school-based, and I am in favor of passing the amended section 5-40-23, physical therapy in a school-based setting. And I'm in favor because the Department of Health rules and regulations that all PTs have to follow for licensure states that a physician referral needs to be obtained every 90 days for continued PT services. But PTs that deliver services according to children's individual education plan or an IEP or in the early intervention setting, an individual family service plan should really be exempt from the request because the children are determined eligible to receive PT services under an IEP or IFSP by law according to the Department of Education. And the service care plans are written for a year's time according to the IEP and the IFSP, and that's what we as physical therapists working in a school-based setting focus on. And in addition, at no point in the process of determining an IEP or an IFSP is a referral of a physician necessary. So we're looking for the alignment of our licensure and the rules and regs in the Department of Health to really align with the Department of Education's request of the continuation of services under the IEP and IFSP. I'm open for any questions.
Thank you, Natalie. Are there any questions for this witness? No? Thank you for your testimony. And
thank you so much.
Yeah, and that concludes the verbal testimony and the hearing on Bill number 6129. Oh, I did that already. Okay. Okay. Next is Bill number 6019 by Representative Fogarty.
Thank you. I'll sit here if that's okay. Yes, House Bill 6019 is regarding an insurance sickness and policies. The Act will require insurance carriers, nonprofit hospital service plans to, maybe I should go up to the, oh, there we are, okay. Nonprofit hospital service plans and nonprofit medical service corporations and health maintenance organizations to cover the cost of breast ultrasounds or an MRI breast exams for any patient receiving notice of dense breast tissue. So what happened a few years back is that the House passed some great legislation that said that people who had dense breast tissue had to be notified that they had dense breast tissue. And just plain simple dense breast refers to appearance of breast tissue on a mammography. It's normal and it can be a common finding. The problem is that, and nearly half the women have that, but the problem is that it can make it more difficult to see any type of breast cancer on a mammogram. So when people are notified that they have dense breast tissue, the next step should be that we should provide them at no extra cost, these women or men, the opportunity to receive a screening of a breast ultrasound, a breast MRI, or a digital breast tomosynthesis, which is more or less like a 3D type of a breast screening. Just for peace of mind that they're not missing any type of a cancer. So this is really, and it reminds me of some of the other bills that we've heard tonight, like the colorectal cancer. By just doing these extra types of screenings, an ounce of prevention is worth a pound of cure versus, paying for, this, as a second backup to the first, test, that we can prevent people from going long-term in treating breast cancer down the road. If we can catch it earlier, the sooner the better for any woman. I don't know anybody out there. I know personally I've had friends who've had this issue happen. Very, very scary thing to hear, you have breast cancer. But the sooner we diagnose it and we get it taken care of, the better. So when people do come back and they say, oh, you have dense breast tissue, well, what was hiding behind there? You're always going to be thinking about it. So people deserve peace of mind. So that's really what this bill is about, and making sure that women have the opportunity, and men again, to go in and have another type of a service to review and find out if they have breast cancer. So I'll take any questions.
Thank you, Representative Fogarty. Did you happen to know if there's a fiscal note attached to this?
There isn't a fiscal note attached to this. I know that the Department of the Healthcare Insurance, since we've taken on paying for extra, Medicare, Medicaid reimbursements, that there would be a cost associated with doing that. But again, I think that it's being foolish to worry about doing an extra test when you're going for treatment down the road if you miss. So that's always been my contention. I know that they always push back on that. But again, an ounce of prevention is worth a pound of cure. You're going to pay the money later down the road if we miss something.
Thank you. Are there any questions for Representative Fogarty? Okay, we'll go to our verbal testimony. And hello, Patrick.
Yes.
Hi, this is Representative Donovan. You're testifying on Bill 6019. You can proceed.
Thank you, Representative Donovan. I'm here today representing the Rhode Island Radiological Society, which are the doctors who perform and interpret X-rays. We strongly support this bill. We believe that House Bill 6019 addresses a critical issue, as just mentioned by the sponsor, Representative Fogarty. We thank sponsor Fogarty for putting this bill in, and her commitment to keep putting this bill in, and hopefully this will be the year it passes. And also her she keeps adding sponsors every year, and we're very happy to see that. The law currently requires that insurers pay for 2 screening mammograms each year when recommended by a doctor. And there's 2 conditions listed. One is that they've had breast cancer within the last 5 years, or they're at high risk due to a genetic predisposition, the BRCA gene, or they have a high-risk lesion. This would add a person who has received notice of dense breast. So we are really grateful to put this extra notice in, because this is one of the more troubling conditions and more difficult. And we also congratulate Representative Fogarty for putting in the DBT, because what this does at no extra cost, this is almost like a CAT scan, or they can look at slice per slice of a picture, very similar to what we consider in a CAT scan. So on a personal note, I lost my mother and my father's oldest sister to breast cancer. My law partner of 15 years, Kathleen Burt, died 18 years ago at a young age from breast cancer. So I have a personal support for this bill, and I personally thank the sponsors. And hopefully this bill this year will move, and we can move forward and have a better response system for those women who have been diagnosed with any of these 4 conditions. I'd be happy to answer any questions. Thank you.
Thank you, Mr. Quinlan. Are there any questions for this witness? Thank you for your testimony.
You're welcome.
That concludes the verbal testimony, and we did have written testimony submitted by the Office of Health Insurance Commissioner Patrick M. Teague, who says that this bill is likely to have a financial impact. All right, that concludes the hearing on 6019. Is this the next one? Okay.
Thank you, Vice Chair Donovan. We are going to move to House Bill 6015. This is a bill by Representative Price regarding an act regarding to health and safety. I will read the synopsis of the bill, and then we have probably, looks like 10 witnesses who will be calling in. This act would require the immunization informed consent forms to include language that the vaccine provider has given the recipient a copy of the vaccine manufacturer's package insert listing the vaccine's ingredients, contraindications, potential adverse reactions, including death, as well as the vaccine maker and lot number. If passed, this would be enacted and take effect upon passage. Are there any questions from the committee at this point? If not, we will, Representative Kassar, go ahead.
Yeah, I just think is the bill sponsor going to be presenting the bill at all?
The bill sponsor will not be here to present. We do have some witnesses who are very well versed in this, so if you have questions regarding the actual legislation and what it means, we can go ahead and do those questions during the testimony.
Okay, great. Thank you.
Thank you. Okay, we'll have our first witness, please. Hello, Madalena.
Hi, good evening.
Hi, Madalena. This is Chairman Casey from the Health and Human Services Committee. You are here to testify on House Bill 6015. If you would go right ahead with your testimony. Representative Price was not here, so I just read a synopsis of the bill, and I know there'll be some questions for you.
Wonderful. Thank you so much. Thank you for your time and for your service to Rhode Islanders. I would like to present you with information to support House Bill 6015, which would protect a patient's right to know relevant information at the time of vaccination. Much of the information included in House Bill 6015 is unknown to the general public, which only serves to highlight this need for transparency. I often hear concerns that too much information may lower vaccine compliance. When factual information gives people pause, we shouldn't be withholding information. We should be improving the parts of the program that gave us pause. Wanting to improve a program does not make one anti-vaccine. In written testimony submitted by Dr. Alexander Scott, the Department of Health opposed House Bill 6015 on the basis that patients are already provided vaccine information statement sheets, commonly referred to as VIS sheets. However, the CDC directly states that VIS sheets are not informed consent. Doctors aren't even required to actually give them to patients. It suffices to have a copy of the VIS sitting somewhere in the doctor's office. One of our advocates at the Rhode Island Wellness Society found her doctor's VIS sheets sitting under a pile of magazines on a little table in the corner of the office. That is not informed consent. In reality, the VIS sheets read more like promotional flyers than anything else. Each one is a double-sided single page of general information. I've emailed the committee my written testimony so that I could provide you with VIS sheets and package inserts. I invite you to compare a VIS to a corresponding package insert to see for yourself. Take the hepatitis B VIS, for example, which does not mention that the longest infant safety trial of any of the hepatitis B vaccines was 5 days. The Recombivac's hepatitis B vaccine safety trials monitored a grand total of 147 infants and children combined for only 5 days to determine that the vaccine was safe for nearly all newborns. The VIS completely omits all post-marketing data and makes no mention of the fact that not all hepatitis B vaccines are created equal. If you go to section 6.2 of a hepatitis B vaccine package insert, you will find a list of more than 30 serious reactions that were reported following vaccination, with a high enough frequency that they were included in the post-marketing data. These reactions include autoimmune and nervous system disorders such as lupus and Guillain-Barré, which is paralysis, multiple sclerosis, Bell's palsy, seizures, connective tissue disorders, arthritis, pain, visual impairments, and so forth. In contrast, the hepatitis B VIS sheet lists only 8 adverse reactions with a focus on mild ones, such as soreness at the injection site. VIS sheets do not provide a list of vaccine ingredients, nor do they list most contraindications. In fact, the hepatitis B VIS only lists anaphylaxis as a contraindication, despite the fact that Section 5.2 of the package insert warns that hepatitis B vaccination puts premature babies at an increased risk of sleep apnea, which babies can die from. Parents should know this prior to consenting to a hepatitis B vaccine. I recently spoke with one mother whose premature newborn was forcibly vaccinated with hepatitis B vaccine 6 years ago at Women and Infants Hospital here in Providence. She was falsely informed that her newborn would not be released from the hospital without a hepatitis B vaccination. This mother intended to decline this vaccine because hepatitis B is a bloodborne pathogen, and since all pregnant women in the United States are screened for hepatitis B, she knew that she didn't have it. It's transmitted sexually or via an injection, so her premature daughter had virtually no risk of contracting hepatitis B. She had enormous concerns about the risk of adverse outcomes for her newborn because one of her older children suffered seizures and gastrointestinal complications following a vaccination. Her right to informed consent was violated when she was falsely told that her baby was required to be vaccinated in order to leave the hospital. She was so upset that nurses instructed her to leave the room during the vaccination procedure. House Bill 6015 would have protected this young Hispanic mother. Had House Bill 6015 been law, she would have been informed that she has the right to say no. She would have been provided with a vaccine package insert prior to giving consent, and she would have been told about the vaccine adverse events reporting system known as VAERS. VAERS is a government-run passive reporting system used to loosely monitor post-marketing reactions to vaccines. According to the United States Department of Health and Human Services, and I quote, fewer than 1% of vaccine adverse events are reported. So this passive system only captures about 1% of vaccine reactions? HHS goes on to explain, and again I quote, barriers to reporting include a lack of clinician awareness, uncertainty about when and what to report, as well as the burdens of reporting. Reporting is not part of a clinician's usual workflow, takes time, and is duplicative, end of quote. People should at least be told about theirs. Despite low reporting, the government has paid out more than $4 billion in compensation for vaccine injuries sustained by devastated people, many of whom suffer permanent neurological, neuropsychiatric, metabolic, autoimmune, and gastrointestinal dysfunction, as well as sensory integration difficulties, to name just a few things. Vaccine injury is real, and public health officials should be compassionately including injured families in policymaking, rather than dismissing them as a negligible 1 in a million and categorizing them as acceptable sacrifices for the sake of public health. Since December, we've administered about 100 million doses of the COVID vaccine. If serious vaccine injury were truly only 1 in a million, as is always touted by DOH and many doctors, then VAERS should have received a total of 100 reports of serious reactions. As of March 19th, over 44,000 adverse events have been reported to VAERS from COVID vaccines alone, and this is just since December. More than 2,000 families reported a death following COVID vaccination. The narrative of 1 in a million simply does not align with the more than 2,000 documented deaths following COVID vaccination. According to the underreported VAERS, over 800 people suffered permanent disability following a COVID vaccine. Permanent. Over 1,000 had a life-threatening reaction. Nearly 4,500 were hospitalized, and nearly 7,500 required emergency medical care. This means that well over 10,000 people eagerly rolled up their sleeve for a COVID vaccine and were subsequently very seriously injured or died. This is more than 100 times higher than the estimated injury rate of 1 in a million.
Madalena.
Yes, sir.
Excuse me. We're taking quite a bit of time. I'm going to ask you to please just wrap it up as soon as you can, and we have a few questions.
Absolutely, Chairman. One of my last points was that Consumers have a right to know that the 1986 National Childhood Vaccine Injury Act and the PrEP Act shield manufacturers from liability when vaccine injury does occur. I have to ask why the government is disempowering consumers and how this makes any product any safer. I want to know, where is liability, and why aren't we as consumers afforded this protection? And we should at least have the right to know this information. And in conclusion, I want to reiterate that when factual information gives people pause, we shouldn't be withholding that information. We should be improving the parts of the program that gave us pause. And I ask you to improve parts of the vaccine program. Please include the right to know. In order to truly consent, consumers must be informed. I urge you to pass Informed Consent Bill 6015 out of committee and onto the House floor, and thank you very much for your generous time.
Thank you, Madalena. Before we go to the questions from the committee, I would just like to request if you would, the reports that you have referenced, if you could send me a link or get me the information so that I can review some of that. I do want to confirm that or deny that these are all shot related or vaccine related. There's quite high numbers, and I think that also there's a good possibility that some of these people have other underlying conditions that may have contributed to these factors. So if you could provide me with the references that you referenced, I would appreciate that, and we'll go to questions from the committee. Anybody? Okay, so we have no questions from the committee. I thank you for your testimony, and we're going to move right on. Yes.
Chairman Casey, I did actually email the entire committee all of those links, and so they should already be in your email and also on the agenda.
Thank you. Okay,
Wonderful.
I appreciate that.
Thank you so much.
Okay, you're welcome. We're going to move to our next witness, please. Hello, Mr. Daly. Hello, Mr. Daly. This is Chairman Casey from the Health and Human Services Committee. You're here to testify.
Hi, Chairman Casey.
How you doing? You're here to testify on House Bill 6015. We did have a lengthy introduction and testimony from our first expert witness. If you would, please keep your testimony to 2 minutes, please. Go right ahead.
Thank you so much. Good evening. Thank you, Chairman. My name is Joe Daly. I'm from South Kingstown, and I am glad to be here today in support of this bill. I'll keep my testimony short. My question, I have two questions. Why aren't Rhode Island families being provided with all of the relevant information when it comes to the medical procedures, specifically vaccinations, that they're about to undergo? Why are they only receiving the VIS sheet, which doesn't list everything, including all the ingredients or contraindications for that specific medical procedure? Is there a reason why we can't provide that information to families? Shouldn't vaccines stand on their own merits? With any other consumer product that we have, we would receive all those information. And I even think just as simply as when I go to the grocery store and, pick up something from the shelf, I can turn it around and look right there and see what's in it. Vaccines are certainly a much more complicated thing than picking something up off the shelf in the grocery store. So it seems to me that in the effort of health and the effort of transparency for Rhode Island families, that we really give them all that information. If there's some reason why Rhode Island families aren't deserving of that information, I would like to know. Otherwise, it just seems like the most prudent thing to do to support transparency and accountability is to provide all the information that is relevant to each vaccine. That's my point, and I really appreciate the opportunity to be here tonight in support of this bill, and I hope lawmakers will really consider supporting it for the sake of transparency and the benefit of Rhode Islanders. Thank you.
Thank you, Mr. Daly. Are there any questions for the witness from the committee? Okay, we're going to move on to our next witness.